and they gave them a sugar pill. They didn't tell them. No one knew which was a sugar pill, the placebo. Another group got 1 milligram of rasagiline. The other group got 2 milligrams of rasagiline, and they went out 36 weeks. So there's a little dip in this scale. So what this scale is, is a scale that we use to figure out how bad a person's Parkinson's is. And if you've been to see me or any of my movement disorder colleagues, it has to do with this, and that, and the walking and all that stuff. It's also the questionnaire. Do you have drooling? Do you have nightmares? How's your thinking and memory? Are you depressed? So there's a whole rating scale. So that's what this scale is. So people who got placebo, their Parkinson's got a little bit better, because that's the placebo effect. It's a big deal in Parkinson's. People who got 1 milligram of, well, that's the placebo. Actually, here the placebo is pretty flat. They didn't change. This is 2 milligrams. They got a little bit better. 1 milligrams up there, they got a little bit better. But the trick was, after 36 weeks, they switched everyone to the active drug. So all the people who were getting sugar pill, they then got the new pill, which was actually medication. So what were they trying to figure out? So there was a group of people that got medicine 36 weeks before the other group, and then they followed them along. So in the 2 milligram group, if you look at how bad their Parkinson's was, all the way out at 72 weeks, it was the same. So what that tells us is, if you start a sugar pill for 36 weeks, and then you start the active medicine, you're no different. So there was no benefit to starting the medicine earlier. So that would argue there was no neuroprotection. So it failed. The tricky part was, if you look at 1 milligram, the people who started earlier never got as bad as the people who started later. So the company, who wants to make money, thought this was good evidence that this was neuroprotective. In other words, the earlier you start Azilect, the earlier you start rasagiline, the better you'll do. So everyone ought to be on this medicine. That's what the company would want. Now the FDA looked at the trial and looked at the data at 2 milligrams, which was, in a previous trial, was the better dose, and looking at the way the trial was done, decided in a vote of 17-0 that the medication was not protective. But I got to tell you, when I look at this, and people ask me, Dr. Savitt, would you take this medicine if you had Parkinson's? I probably would consider it pretty strongly. Now, one caveat to that is, it's very expensive, so you got to make the determination whether it's worth it. The other caveat is, I give this talk for the company that makes it, so I'm a little tainted. But the only reason I give this talk is because I believe some of this data. And so if people are able to take this medicine, I put them on it. But the second that they have a problem, or the second they tell me it's causing financial distress, we get rid of it, because the evidence is so weak, and the FDA voted 17-0 that it's not protective. Is there a question back there?
I started out on 0.5 and went to 1, and when I went to 1, it was dramatic difference. But I understand, I understood until today that 1 was the max dose, but you got 2 milligrams.
Right, so it's a good question. So based on this study, 1 milligram looks better than 2. And based on the other studies, there is no real benefit. Doesn't seem to be a benefit to 2 milligrams. And we also know the higher the dose is, the less specific it is. So there's something, so MAO is an enzyme, there's a different form. MAO-A, if that gets inhibited, and you can see some inhibition at higher doses, you run a much higher risk of interactions with other medicines. So we get very nervous. So there isn't any data to support using more than 1 milligram, and I've never seen anyone ever get more than 1 milligram, so don't take 2 of them. Stick with the 1. The reason why 1 may make you feel better is it does prolong how long levodopa works, separate from any protective effect, and it also, people have symptomatic benefit. So these people, they felt better. And there's no doubt that the medicine improves Parkinson's symptoms. It just doesn't do it very robustly, and it probably doesn't do it in a way that's neuroprotective. All right. All right, so we'll move along here. So there's been interest in urate. So this was a study actually I was a part of a long time ago, where they found that people who have a higher blood uric acid level, uric acid is the same thing that gives people gout, but they found if you have a higher uric acid level in your blood, the highest level, and you happen to be a man, then your Parkinson's disease progression may be slower than if you have lower urate levels, or if you're a woman. So these were very preliminary data that came out, but they kind of sparked another trial of a medicine or a drug called inosine, which you may have heard of recently. Inosine was found to be safe, and we're going to figure out whether or not it's effective in slowing the course of Parkinson's. I have patients who have Parkinson's and gout. That seems like that shouldn't happen, but it does. If it's protective, I don't think it's going to be a big effect. It's actually a trial that we passed on because I wasn't too excited about it. But it's ongoing. They are I'm not sure if they're recruiting, I guess they're phase 3, which is looking more for actual benefit as opposed to dose and safety, is ongoing. This is an interesting molecule. It's called GM1, may be protective. There's not only this study, which was done years ago, but there was a study that just came out recently that looked at imaging that suggests that injections of this material may actually slow progression. This is that same kind of study I showed you before. These people got active drug, these people got a delayed start of the active drug, and these people got nothing. And it seems like over the course of time, injections of this drug may actually be protective. I haven't seen much else about this particular study since the initial studies came out a few years back, except for the imaging looking at the same group of patients. So I review grants, and there's always someone proposing to do more research on this. Some of them get funded. I'm not sure where it's going. But another good reason to have hope. Byetta is another medication. It's actually already approved to treat diabetes. This is different than that other diabetes medication news that came out recently. But this also what seemed to be protective. People who use this medication seem to have a slower progression of Parkinson's and also improved thinking and memory scores. Why we talk about this study is what's interesting about it, even more so than maybe the drug, is the way the study was designed, where people knew whether they were getting drug or not, but what they did is they recorded the patient's exam, and then some third party who was blinded did the evaluation. So those of us who do Parkinson's research, this is a way to make the trials a little bit easier to do and a little bit less expensive, and maybe a way to look in the future of another way to look at these type of trials. There's been a lot of interest in something called GDNF. Has anyone heard of that? It's a growth factor. It was used in infusion therapy by a company called Amgen. They subsequently pulled the trial. I had a few patients who were getting it, thought it worked. There's a new trial going on at the NIH using gene therapy to try to get an increased amount of this particular protein in the brain that's supposed to be neuroprotective. There's a lot of different trials, gene therapy trials using this and similar medicines that have failed, but a lot of people ask me about this, so I include it just in case there's any questions about it. And I don't think that there were. There's a couple other studies I'm just going to touch on briefly. Isradipine is in a phase 3 trial. This is a calcium channel blocker already approved to treat high blood pressure. What this does is it changes, at least in animal models, changes how the brain cells that make dopamine signal. And instead of using calcium, they switch over to sodium. And for some reason, in these mice models, they're protected against Parkinson's. So we get very excited when there's medicines that are already out there that we can kind of repurpose to treat Parkinson's. So we know that the studies that the doses that we think we need to use are safe in Parkinson's patients, and so there's going to be a trial to see whether or not this medicine is effective as well. There's a trial finally got going on the kind of the Nicoderm Habitrol patch, nicotine patch, to see if that slows Parkinson's. And the pioglitazone trial is the one that I think maybe is what you're referring to, failed recently. So there's creatine, CoQ10, pioglitazone, A couple of things, immunophilins, SEP-1346, a variety of medicines that went through these protective trials that all failed, unfortunately. So there's a lot of excitement. You give these drugs to animals, you protect them from getting the animal versions of Parkinson's. You give them to people, doesn't seem to help. I know that there's still people on CoQ10 and creatine, but the data doesn't support using it. Yeah, skip over that. So where, again, this great excitement is in these alpha-synuclein therapies. And so remember, this is that protein that can be modified, it can be cut up, things can be added onto it that make it fold in an abnormal way, and that acts as a seed to make other synuclein proteins misfold that way too. And we think this is what kills the cells that make dopamine. All right, so how do we figure out a way to block that? So Apheris is a company that's actually inoculating, like vaccinating people with synuclein to try to get them to make antibodies the same way we get protected from the flu or pneumonia or other communicable diseases, to figure out a way to clear synuclein. It's in phase 1 trial in Parkinson's disease, and it's actually in a further along trial for people who have multiple system atrophy, which is a more aggressive form of Parkinson's. Those of us who are interested in this type of therapy, and we're doing a similar trial at our office for a different disease, if you actively immunize someone, so we're making the body make antibodies against the protein, synuclein, there is that fear that you'll develop an autoimmune disease. So this company is taking somewhat of a more risky approach to see if they can clear this abnormal protein, but the trials are moving forward. There's also Prothena and Roche, I think in combination with Michael J. Fox, are looking at a way to give people an antibody to synuclein. It's intravenous to see if they can clear that abnormal protein from the brain. Something very similar was done by Lilly and Biogen, clearing a protein from people who have Alzheimer's disease. And so there's a huge amount of excitement, not only in the medical field, but in the Wall Street Journal and these companies in order to develop these new therapies. Biogen has already launched their phase 1 trial of this too, and there's also another BioArctic, another company who's also bringing this therapy into trials. So we don't know how it's going to work out. We haven't seen data in Parkinson's patients. We do know that these antibodies can lower the amount of these proteins that we can measure in the cerebral spinal fluid. So that's when you get a lumbar, spinal tap. They take the fluid out, the fluid that bathes the brain and the spinal cord. These antibodies can lower the amount of synuclein that's there, but whether or not it clears the brain of these proteins and whether or not it has anything beneficial and whether it has any downside, we don't know. We're going to do, in our office, we're treating PSP actually with something similar. We'll probably be the first people to put this antibody in a person with a disease. And I got to tell you, I'm scared. I don't know what we're going to see. This could be quite a hazardous therapy, but people are desperate, and we're hoping it's going to be positive. So it's tough to watch. I mean, this could be really exciting stuff. It may be a bust, and we just don't know. On top of that, there are non-antibody therapies. There's something called Neuropore, which actually protects the synuclein from being modified in a way that makes it toxic. We all have synuclein in our brains, whether we have Parkinson's or not. The problem is, with Parkinson's, the synuclein is misfolded. It turns into something bad. This is a way to keep that from happening. Nilotinib is an interesting medicine. It's already approved for the use of treatment of leukemia and lymphoma in people who have cancer. There's a group at Georgetown, Fernando Pagan's group, who was looking at this to actually treat people with Parkinson's disease. And he's very excited about what he sees, but we'll find out some more concrete results in October when he's set to actually present some of this. Phenylbutyrate may also help clear synuclein from the brain, and ceftriaxone, which is just an already used antibiotic, may also play some role. So these are all ways to target this abnormal protein. Remember, this is the one that if you inject it into a mouse, you can give mouse Parkinson's disease. This is something that looks like an infection that can transfer Parkinson's disease. Yes?
I'm on Exelon patch.
Uh-huh.
Every 24 hours, and the difference is
Yeah, and I'll talk about that. That's my last chapter. That's part 4. That's treatment. So this is all things that may reverse or slow down the progression of the disease. So at this point in time, we have nothing to do that. We don't have any medicine that I can prescribe that I can be confident is going to reverse the disease process or slow it down. That's why these trials are ongoing. But at this point, we got nothing. So I see someone who has Parkinson's and they say, what can I do? I think I tell them, we think exercise is good for you. Definitely do exercise. That may be protective. I think most people who exercise a lot do better. Some people, I talk to them about the rasagiline or Azilect or selegiline, which is a related molecule that may be protective. Again, there's not good proof. But all the other things, you know, the vitamins that are out there, looked at vitamin E, selenium, again, CoQ10, creatine. So far, nothing has been proven to work. So that's what I got about protection. Again, the other take-home is the synuclein therapies. Whether or not these antibodies are really going to live up to their promise, I really hope so. Any questions about that while I have a sip of water and rescue my voice? Yes?
What's the normal time for a human study?
So, that's a good question. So the question is, how long is a human trial? For neuroprotection, because the disease progresses slowly and is so variable. I mean, if you belong to a support group, you can see people who've been in that group for 15, 20 years who look better than the person who's only had it for 3 or 4 years. So in order to kind of correct for all the variability and the fact that it's a slowly progressive disease, it may take a long time to figure out whether or not something's protective. And that's one of the reasons why, so these NET-PD trials, these protection trials, they're done in a very quick and dirty way. And what they're looking for is to define something called futility. So if a person on a protective therapy is doing worse, odds are they're not protective, even if you look over a short period of time. But most of these trials are going several years. And even at that point, you wonder whether or not they've gone long enough. But the problem is it's very expensive to do these trials. The longer you try to keep a person enrolled in a trial, people move, people get tired of going to the visits, they're sick of having them, remember these 5 words, they're sick of it. So people don't always want to stay in trials for an extended period of time to take an experimental drug. The other thing is there's always news. And this has been a problem for people in trials with me. They say, oh, can I get on that new stuff? It's like, yeah, you can do whatever you want, but it's going to void what we do. So if you go on some new protective therapy and something good or something bad happens, we don't know. We don't forbid people from doing that, but it may mean that when we find out whether or not they're better or worse, we don't know what to make of that, because now they're on some new therapy that may be playing a role. So it's really hard to keep people in these types of therapies for many years. But the other therapies, the other trials, we're doing a trial. It's actually fairly prolonged. It's a month. I mean, you give people medicines that improve their Parkinson's, you can know in a matter of days or even a week whether or not it's working or not. So some of the trials for therapy are very short. We like to follow people long afterwards, but the exposure to the drug can be very short, whereas the protection trials go on much longer.